with Mike. Okay, so Assalamu alaikum everyone. I'm Jude Abdeen, and inshallah today I'll be explaining the embryology lectures with my colleague Anam. طيب. So I know embryology هيك at the beginning it sounds very tough and complicated يعني حتى to me personally. But if you understand step by step شو عم بصير and at the end you can make draw the whole scenario story alone, it would be very easy. Okay? But if I have only one advice for you is that do not skip any step. You تحكوا خلاص مو مهم اني افهمها بفهم الستep اللي بعدها. Then in each step you're building up the info. Okay? You guys took the menstrual cycle, صح? You know it's approximately 28 days. It differs from female to male. It could be more, it could be less. هلا let's assume خلاص it's 28 days. اللي رح نحكي عنه in the first lecture which is day 14. This is where ovulation happens and this is where fertilization happens. Okay? I'll go through the stages of the menstrual cycle. We have the menstruation here where the endometrium it sheds, so bleeding happens. This is not our focus today, and we want to see what happens during pregnancy. Okay? We have the follicular phase. This phase it is controlled by the boss hypothalamus. Okay? The hypothalamus will secrete gonadotropin releasing hormones. Okay? So it will stimulate the anterior pituitary gland to release what? FSH and LH. Okay. In the follicular phase, what we're doing, we're focusing on the follicles. يعني we're trying to make the follicles age to be matured more. حلوين؟ بعدين we have the ovulation phase. This is the phase where the ovaries secrete the oocyte. حلو؟ بعدين we have the luteal phase. Here we have the remnants of the follicles. هلا يعني I'll explain each one in details. In the luteal phase, the remnants of the follicles will make corpus luteum, and the corpus luteum will secrete more hormones. Again, we have the follicular phase. Okay. The main controller here is the FSH from its name, follicular stimulating hormone. It will stimulate around 15 to 20 primary follicles. But at the end, we'll have only one mature follicle, the Gravian follicle. Look. We have the oocyte, بعدين we have the zona pellucidum, بعدين we have what? Granulosa cells, which later on will become the coronary data. We have the theca interna, theca externa, and in the middle we have the fluid cavity, which is the atrium. This is what? Gravian follicle. حلوين؟ طيب. The FSH also with the help of the theca interna رح تعطينا precursors to make estrogen with the help of granulosa cells. Okay? The estrogen رح يعمل عنا positive feedback. It will re-stimulate the hypothalamus. Again حيصير عنا gonadotropin releasing hormones. Again رح يعطينا FSH and LH. Is it clear? Okay. طيب. بالovulation phase, here we have the ovary. Okay? وهنا عندنا the uterine tube. At the end of the uterine tube عندنا like finger-like structure, the fembra. It will massage the ovary to release the oocyte. Okay? And the ovulation happens whenever we have a peak in the LH. لما تشوفوا we have a huge surge بال LH على طول ovulation happens. Okay? And you know إنه الoocyte it gets arrested لأي stage بالضبط؟ قبل metaphase 2. Prophase 1. بعدين عند الovulation بتصير لmetaphase 2 until ovulation. Is it clear? What else do I need to mention here? Okay. In ovulation phase, we have two more important things. هلا احنا we said the oocyte is covered by theca interna and theca externa, صح? When we release the oocyte, احنا بس بدنا الoocyte مع the zona pellucida and the coronary data. We don't want the theca interna and theca externa. So we need what? Collagenases, okay? To rupture the follicle. تمام? And also to release the oocyte, we need contraction to happen. So we need what? Prostaglandin. حلو? Okay. Moving on to the luteal phase, which is controlled mainly by the progesterone. I'll tell you how. But we said the theca interna, theca externa won't leave the ovaries. فهدول remnants they will make the corpus luteum. This if fertilization happens. If fertilization does not happen, the corpus luteum will turn into white scar fibrous tissue, which is corpus albicans. Okay? But again, we have the ovulation phase. صار عندنا release of the oocytes. Okay? صار عندنا release of the oocytes. Here the corpus luteum will secrete progesterone. Okay? The progesterone رح تعطي الoocyte 10 days. It's a deadline for it to be fertilized and to be implanted. إذا صار عندنا fertilization and the implantation happened in the endometrium, the oocyte رح تحكي للcorpus luteum, hello, I'm here, give me more progesterone. Progesterone, what does it do? Do you have any idea?
Shedding?
Exactly, it prepares the endometrium for implantation. يعني it thickens the wall of the endometrium. Okay? If fertilization happens or implantation happens, more progesterone will be secreted, and Anam will explain to you that this is done by the HCG. Okay? If fertilization does not happen, obviously we won't have implantation. But here there will be shedding of the endometrium and bleeding will happen, menstruation. Okay, so fertilization, خلاص, now we have the oocyte in the uterine tube. Ejaculation will happen. We have around 500 million sperms. They will enter through the vagina, بعدين cervix, uterus, بعدين uterine tube. From those 500 million sperms, the vagina is super acidic, so they will die. At the end, 500 will only reach the uterine tube. But for the sperms to fertilize the oocyte, two processes should happen: the capstation and the acrosome reaction. عشان يمرقوا لأن acrosome reaction, they should pass the capstation phase أول. Okay? Capstation phase is like we're locking the sperm. شوفوا كلمة cap. We're removing the cap of the sperm. We're removing the glycoprotein layer. Okay? Which increases the motility of the sperm. Okay? The acrosome reaction one, we have a release of the digestive enzymes, trypsin-like substances, to help in digesting the zona pellucida for the sperm to penetrate the oocyte ويصير عندنا zygote. Okay? At the end of fertilization, شو بصير عندنا? We're restoring the number of the diploid chromosomes. Then how many chromosomes do we have in the oocyte? 23. 22 are autosomal. One is the sex chromosome, which is X. For the sperm, it could be X or Y. Okay? So we have the diploid number of the chromosomes. We determine the gender of the baby, whether it's X female or XY male. And here بصير عندنا initiation of the cleavage. Okay? In the cleavage, أول شيء عندنا zygote, بعدين 2 cells, 4 cells, 8 cells, بعدين 16. Here we have the moria. In the uterine cavity, we have a lot of fluid. But this fluid will enter the zona pellucida. حيصير عندنا hatching. أصلاً for the implantation to take a place, the zona pellucida should be broken down. Okay? The fluid will enter through the morula, here. But the cells will change their place. We'll have the inner cell mass, the outer cell mass, and the cavity, fluid cavity, which is called the plastocele. Again, we have the inner cell mass, it will give rise to the embryo. We have the outer cell mass, it will give rise to the trophoplast, which is the trophoplast, it will give rise to the placenta. And we have the cavity, which is called the plastocele. As a whole, this is plastocele. Okay? Do you have any questions so far? Sure? Okay. Then, for the layers of the uterus, we have 3 layers. We have the endometrium, which is the innermost layer, and this is where implantation happens. Then we have the myometrium, so it's the muscle of the uterus, and this is where contraction happens. And finally, we have the perimetrium, which is the peritoneal cover. We said we have a lot of phases in ovary, صح? We said we have the follicular phase, luteal phase. The uterus also, it has its own phases. We have the menstruation. We don't care about it. We have the proliferative phase. In the proliferative phase of the uterus, fertilization takes place, and this is controlled by the estrogen. In the secretory phase, implantation happens, and this is controlled by the progesterone. Okay? Question time. Who would like to read?
A 28-year-old woman has normal ovulation, but sperm from her partner can reach the ampulla, yet fail to fertilize the oocyte. Laboratory analysis shows normal sperm count and motility, but abnormal membrane composition. Which step is most likely to fail?
What do you think?
B.
Gestation?
Yes. It is. It is B. Okay. Next question. B. No, عادي, anyone else. يلا جاهز. You don't have to answer it. يلا, go ahead.
A woman's endometrial biopsy shows long coiled glands and a thick secretory lining rich in glycogen. At this stage, which hormone maintains this appearance and why?
Which hormone prepares the endometrium for implantation? Yes, correct. Progesterone.
Hello everyone. I will be talking on the developmental changes which occur in the 2nd and 3rd week. So first I'm going to begin with a question. Can someone read?
A woman has a pregnancy test performed 8 days after fertilization, but the result is negative. 2 weeks later, it turns positive. Which event explains the initial false negative result?
is it A?
HCG.
Yes. So the syncytial trophoblast releases the HCG. Also as a tip, you can remember the syncytial trophoblast, you have the SYN, it synthesizes the hormones HCG. This is just in another way the question can be asked. Okay. Can someone read?
Which of the following best describes the primary villi? Cytotrophoplasts covered by syncytial.
Yes. We're going to look at this process also. Okay. Last question.
A woman experiences slight bleeding around day 13 post-fertilization, which she mistakes for menstruation. What is the most likely cause?
Yes. Okay. So we begin with the week 2, which is characterized by implantation. And what do we see in week 2? The formation of 2 layers. Okay. Okay. So in day 8, so how does implantation exactly occur? It occurs because there is a wound or a defect which is created in the endometrial wall. And what are the main layers of implantation? The trophoblast. The trophoblast divides into cytotrophoblast and the syncytial trophoblast. The cytotrophoblast is uninucleated, whereas the syncytial trophoblast is multinucleated. Okay, and now what happens to the inner cell mass? This is the main thing. So in implantation, you will have the 2 layers, the epiblast and the hypoblast. Okay. Then the 2 cavities are formed. Over here is the amniotic cavity, and over here is the blastocoel. Okay. So the amniotic cavity is surrounded by. Is it
Epiblast or
yeah.
amniotic cells.
Amnioblast, which and the source of amnioblast is the epiblast cells. Okay. And in day 9, we see that the blastocyst progresses towards the endometrium. Okay. And the wound or the defect which was there in the endometrium, it is covered by this coagulation plug over here. And what do we see in the trophoblast? We see some spaces or vacuoles over here, you can see, which are called trophoblastic lacunae. Now these trophoblastic lacunae, it keeps on enlarging, okay? So it keeps on extending. Okay, so it keeps on extending. And in the inner cell mass, we see the hypoblast cells over here. The flattened hypoblast cells forms the exocoelomic membrane, which gives rise to the primitive yolk sac. So the epiblast cells are responsible for which cavity? Amniotic cavity. And the hypoblast cells? Yolk sac. Okay. And also to keep in mind that the endometrium will contain the sinusoids or the leaky capillaries. Okay. Okay. Now we see the lacunae which was in the trophoblast. It keeps on extending like I mentioned before. So it progresses till it reaches the sinusoids, and then it fuses to form the uroplacental circulation. And then in the inner cell mass, we see the extra embryonic mesoderm, which is in between of which 2 layers? Not 2 layers, which is in between?
The cavities and the cytotrophoblast.
Yes. Okay. And we see an additional new cavity which is formed, that is called the chorionic cavity over here within the extra embryonic mesoderm. Additionally, we also have the decidual reaction in the endometrium. What happens in the decidual reaction? Does anyone remember? Sorry?
What happens?
Yeah,
Inflammation.
in the decidual, during decidual. Yeah. So basically the cells, it changes the shape because it gets accumulated with glycogen and lipids. So it becomes polyhedral in shape. Then finally, day 13, we see the formation of primary villi. There was a question about it. So the cytotrophoblast forms the finger-like projections known as the villi. And then the chorionic, oh yeah, I forgot to mention that. Okay, yeah. So the chorionic cavity keeps on extending also. So it covers the entire amniotic cavity and the primitive yolk sac. Where does the chorionic cavity not cover? Where is it not present? What's the entire name? Connecting stalk, yeah. Which is the future? Yes. Okay. Okay, so now the hypoblast cells which are over here, it keeps on proliferating to give rise to the secondary yolk sac. So first we have the blastocoel, then the primitive yolk sac, and finally the secondary yolk sac. Okay. Okay, that's it. We are done with implantation. Can someone read? Okay.
A 32-year-old woman presents with severe abdominal pain and vaginal bleeding at 6 weeks of gestation. Transvaginal ultrasound shows an empty uterus and a gestational sac in the right fallopian tube. Which of the following best explains the complication? B.
Yes. And we know that ectopic pregnancies mostly happens in the fallopian tube. Okay. Anyone wants to read? Okay.
A 35-year-old pregnant woman has painless vaginal bleeding in her sixth month of pregnancy. Ultrasound shows the placenta is covering the cervix.
The
What
answer is
function?
already there. Yes. And where exactly in the cervix?
Internal os.
Yes. Okay, so that's how we cover the abdominal implantation. Okay, one more question. Oh yeah.
Which event marks the transition from primary to secondary villi? Penetration of do I read or?
No, it's okay. Does anyone know the answer?
B.
Yeah. Somebody else can also answer. Okay. Now we are going to the week 3 of development, okay? So I'll explain this, but can someone just guess it quickly? Yeah. Okay. So in week 3, we see gastrulation and the formation of notochord. So how does gastrulation exactly happen? By the formation of primitive streak, which is a narrow groove in the epiblast, okay? And in the cephalic end, we see the primitive node, which contains the primitive pit. And now the gastrulation begins by the epiblast cells, which are migrating downwards, and this process is called?
Invagination.
Yes. So it migrates downwards and it reaches the hypoblast cells. It replaces the hypoblast cells to become the endoderm. And in the middle, we'll have the mesoderm, and the remaining cells are called the ectoderm. And the factor which is controlling the process of gastrulation is called the fibroblast growth factor. Now we are going towards the formation of the notochord. So it begins with the precaudal plate. So how does just to keep in mind that there are two places we don't have the mesoderm. It is the oropharyngeal membrane and the cloacal membrane. The oropharyngeal membrane is the future?
No.
Yeah, and the cloacal? Yes. Okay, so the precaudal plate, it begins with the cell, which was in the primitive node. It migrates down to the cephalic end, and it is lying between the oropharyngeal membrane and the notochord. We will now see the formation of notochord. Okay, so it begins with the gastrulation process. So we see that the epiblast cells are migrating down. It invaginates down, and then it fuses with the hypoblast. Okay, those cells are called the pre-notochordal cells. They fuse with the hypoblast, and then when the hypoblast cells is replaced by the endoderm, it detaches. So in the meantime, it forms the neuroenteric canal. So that is called this is called the notochordal plate, and the notochordal plate folds in such a way to form the definitive notochord. Okay. Before I proceed, does anyone have any questions? Okay. This is about the defects, so just answer it. It's fine. Yeah. What is the condition called?
I forgot the name.
Does anyone remember? It starts with an S.
Yeah.
Okay, serenomelia. Okay. Very easy.
A.
So these are the gastrulation defects. Okay, now we are going to the third lecture and the final lecture of embryology, which is the embryonic period. Okay, only one question over here. Someone read it actually. Can you read?
Half-week embryo shows failure of neuric crest, migration through the anterior solent region. Which structures may be affected?
It's memorization, I know. Okay, we will look at it, okay? Forget it for now, I'll just explain. Okay, so we saw the ectoderm previously, and now it has got 4 derivatives of ectoderm. The central nervous system, the peripheral nervous system, the sensory epithelium of the eyes, ears, and nose, and finally the epidermis, which includes the hair, nails, and skin. Okay, does anyone remember which derivative of CNS gives rise? Okay, I'll just give you a hint. Is it the neural tube or neural crest cells? Yeah. Okay. So now we are going to the formation of neural tube. How does that begin? So it begins with the notochord. The notochord and the precaudal plate stimulates the overlying ectoderm over here to become thick, and that is called the neuroectoderm or the neural plate. So basically the neural plate then folds, and then a groove is also formed down, okay? That is called the neural groove. So the folding gives rise to the neural tube. Now this folding begins in the cervical region and it proceeds in the cephalocaudally. The anterior neuropore closes later, which is at day 25, and the posterior neuropore at day 28. Okay, now we have the neural crest cells. So what are the neural crest cells? They are basically derivatives from the neuroectoderm over here, and it migrates down to the mesoderm. And it has 2 pathways, the dorsal pathway and a ventral pathway. I have made a mnemonic over here. For the dorsal pathway, you can remember DO, so DO dorsal, and the pigment cells, which you associate with the melanocytes. Then in the ventral, we have the mnemonic SAGE. So there is the Schwann cells, adrenal medulla, then the sensory ganglia, and the sympathetic and enteric neurons. Okay, oh, the answer is there. Never mind, the answer is there. Can someone just, okay. So over here we see the keyword tuft of hair over the gluteal cleft, and that is why it's the closure of the posterior neuropore. What's the condition called again?
Spinal fluid.
Yes. Over here also the answer is written. Just tell which condition is it? Yeah. So ancephaly and spina bifida.
Okay, moving on. Okay, so moving on to the mesoderm layer and its derivatives. The mesoderm, it starts as the notochord, okay? The notochord later on, which is this here, over here. It starts with the notochord, which later on will differentiate on the nucleus pulposus, which is part of the intervertebral disc. Then you have the paraxial mesoderm, then intermediate mesoderm, then the lateral mesoderm. So the intermediate mesoderm will connect the paraxial with the lateral, okay? This is memorization, guys. For each layer, what does it give? Okay? There's nothing I need to explain. In the paraxial mesoderm, we have the somatomeres. It will convert to somites. And the way how I like to memorize or understand this conversion thingy, it's like you have a box of Lego that is like unorganized. When you build something like a building or a castle, it becomes organized. صح? فهون likewise, we have the somatomeres. It's undifferentiated, صح? Unsegmented. Later on, you have the somites. It becomes blocks, segmented. Once it becomes like this, segmented as a somite, it will give us 3 layers, or 3 derivatives. We have the sclerotome, which will give us the vertebrae and the lips. بعدين myotome, what will it give us? Muscles. بعدين dermatome, the derms. What else? Yeah. Then moving on to the intermediate and lateral mesoderm, نفس الشيء. Intermediate will give us the kidneys and gonads. The lateral mesoderm will give us the heart, blood vessels, the gut, كمان memorization. Also check this picture, it's really nice to memorize it. Okay. The lateral mesoderm, later on it will differentiate into somatic or the parietal layer and the splashing or the visceral mesoderm. Okay? The somatic or the parietal, it will move dorsally and it will cover the ectoderm and which cavity? Amniotic cavity. Then the splashing or the visceral mesoderm, it will cover the endoderm and the yolk sac, ventrally. Okay? Okay. During the folding, we have from the head to the tail, we have a folding and we have a lateral folding. Okay? It will give us the gut tube. ماشي? As you can see, it is divided to 3 parts. So we have the foregut, midgut, and the hindgut. The gut tube, it will extend from the oropharyngeal to the cloacal membrane. Okay? The foregut, it will end at the oropharyngeal membrane. The midgut, as you can see, it is connected with the yolk sac. And finally, we have the hindgut, which will end at the bronchial membrane. Guys, do you understand? It's clear?
Yes.
Type. Finally, I love this slide because we have it in here too. So we have angiogenesis and vasculogenesis. Basically, it's the formation of blood vessels. Best, different methods. In vasculogenesis, we're forming blood vessels from scratch, de novo, okay? I don't know if you took this, but in the 5th week of embryology, we have blood islands. They start appearing where? In the yolk sac. Mashi? Later on, it will turn to blood vessels. In angiogenesis, here we're forming blood vessels from pre-existing blood vessels with the help of vascular endothelial growth factor. Okay? Who would like to answer? We said lateral mesoderm, it will give us 2 layers, صح? What are they?
Parietal and distal.
Yes. But what's the answer? Does the distal layer underlies the ectoderm? لا, the endoderm. طيب, the parietal mesoderm, it underlies the ectoderm. صح. So it is C. And the last question.
A.
Yes. Do you have any questions? خلاص we're done.
Hello everyone. Before Abdeen. My name is Shorook and I'll be talking about your repro anatomy. Okay? Very easy lecture. Fairly compared to what we think, it's a bit empty. So I will be focusing on a couple of points that I'm almost certain they will get you questions on. Inshallah this goes well. Okay? Ladies first, as always, we will start with the female reproductive system. Overview, what is this? Done. That's basically all it is. We'll start with the ovaries. They are the primary paired sex organs of females, and they lie in the pelvic cavity. Do they lie in the open? No. They have to be anchored and they have to be enveloped. Enveloped by who? By the broad ligament. Broad ligament is a type of peritoneum. Do you guys remember when we used to get toys as kids and they were between those two very hard plastics? They had to get scissors. It's the same thing. The ovary is between 2 layers of peritoneum called the broad ligament. See how it's sandwiched? Layer 1, layer 2. Okay? But it's also anchored. So not only is it sandwiched, it's anchored by 2 very important ligaments. The more important of it is the suspensory ligament. Suspensory ligament anchors the ovary to where?
Lateral wall.
The pelvic wall, yes. And the ovarian ligament will anchor to who?
Uterus.
The uterus. Great. Why is the suspensory ligament important?
Has the blood vessel.
It has not the vessels in general, so it has vessels and nerves. This is incredibly important to know. So anything that could potentially harm the suspensory ligament will potentially harm the blood supply to the ovary and the nerve supply to the ovary. Very first thing I saw is this could be a very quick clinical scenario question. Okay? This broad ligament, according to what it covers, it has a different name. The only thing mentioned for you is the mesovarium, so just ignore the mesometrium and mesosalping, so you don't need this. So the part next to the ovary from the broad ligament is called the mesovarium. There are other 2 called the mesosalping and mesometrium, which you guys are not supposed to know it. They didn't go into details. Okay? The fallopian tubes. What part is this? Okay. Ampulla. Great. Okay. So intramural, ampulla, fibrum, fimbriae, isthmus, and infundibulum. Intramural. Why is it called intramural? Because the uterus is muscular, and this is the part that extends into the uterus. Okay. The isthmus, what you're supposed to know, this is the most narrow part, and then the ampulla. What's so special about it? Fertilization occurs here, of course. Fimbriae are finger-like structures that guide the ovum that's coming out of the ovary into the fallopian tubes, and what receives it is the infundibulum because it's funnel shaped. So it's kind of like as you're going medial to lateral, it's getting bigger and wider. Okay? That's basically it for the fallopian tubes. The uterine body, star of the show. Okay? The uterus is a hollow, muscular part of the female anatomy. Okay? But the uterus itself anteriorly is flat and posteriorly is flat, and above creates a kind of like a dome. What is this called? The fundus. What's the function of the fundus? لا مش implantation. I don't think you guys took this, but I'll throw it in FYI. The uterus is a pelvic organ. If a woman is pregnant, من كتر ما سبحان الله يعني the uterus expands, it becomes an abdominal organ. Doctors, when they go in for checkups, they feel for the fundus to see the gestational age. Okay, because the more she's into her trimesters, the more the fundus will go upwards. Okay? Relations. I think you're going to hear me say the word relations like 10 times while explaining, because this is incredibly important. Anatomy doctors love giving you scenarios about relations. Tumor in this area, what is it going to press on? Stabbing in this area, what is it going to affect? All clinical scenarios are going to be related to relations. Okay? So the uterine body, anteriorly, who's in front of it? The bladder. How do you remember this? Any pregnant woman in the 3rd trimester goes to the bathroom every 10 minutes. Why? Because the uterus is so big and pressing on the bladder. But remember, bladder is right in front of it. Who's behind it? The rectum. Great. And then inferiorly, what does it open into? What is this? Cervix and the vagina. And then superiorlaterally, what does it get? Where does it get the egg from? The uterine tube or the fallopian tube. Okay. So implantation, we said, occurs in the ampulla. Function of the fundus, we said it. Again, relations are incredibly important. Okay? Cervix, structurally different than the uterine body. It is cylindrical and has a hollow central canal in it. Okay? The cervix extends from the internal os to the external os. The internal os is the point of, converging, the point where the uterine cavity kind of thins out and becomes very constricted. Then you have the hollow tube, and then you have the external os, which opens into the vagina. Exactly. Okay, so superiorly it communicates with the uterus through the internal os, inferiorly communicates with the vagina through the external os. Okay, and this is important because in vaginal examinations, when they insert the speculum, they actually look for the external os as like a reference. You guys, inshallah, will take this when you take clinical skills 0 pro, and you put a speculum in the model. They tell you if it's pointing downwards, if it's pointing upwards, that means you put the speculum wrong. So this is why it's important clinically. Okay? Yeah. Okay, this is so stupid. The reason I'm saying it's stupid is because when I took it last year, I remember it was confusing to me, but it's more simple than you think, okay? I am the uterus, the fallopian tubes, the cervix, and the vagina, okay? If things were easy, I would be standing like this in the body, but I'm not, okay? What did we say? Who is anterior to the uterus? It will go and hug it. It will lean in the front. I know I'm doing this because it's going to stick in your head, okay? And then, so the angle between the axis of the vagina and the axis of the cervix is 125 to 175. It's the bigger of the two angles, basically. So it's not completely bent over. It just hugs the bladder a bit, okay? The angle of the cervix to the angle of the vagina is good? No. I also want to bend, and I'll bend 90 degrees. Why is this important? Because normally, the uterus is supposed to be antero-flexed and antero-verted. Some women are born with retroverted uteruses. مين كان ورا? The rectum. So here's the thing, it's not that big of a deal. يعني they live fine lives, they're usually asymptomatic, but they can have some complications, like they can have pain during intercourse, they can have very painful menstrual cycles. Pregnancy and fertility is not affected that much. It can be, but it's very rare. Okay, but the fact that it's going to press on other structures behind, there are nerves, there are organs, that's what can cause issues. And the normal is supposed to be anteroflexed and anteroverted. Okay. Okay, then we find ourselves in the vagina. Okay, so the vagina, we said the cervix has an external os. صح? This external os extends into the vagina. So this is a person laying down as if you're looking in with a speculum. But the vagina is a tube, right? It's a canal, but we're seen as a canal. So canal is like this, and then I have something in the middle. This separates the vaginal area into supravaginal and infravaginal. And it will also create pockets called fornices. Singular fornix, plural fornices. Anterior fornix, posterior fornix, and 2 lateral fornixes. Now there are a bunch of functions for this. It gives us more surface area during birth, during expansion of the uterus. But the posterior fornix has a clinical significance. Sometimes it is used as an axis during surgery or during a specific clinical procedure. Again, this was not specifically mentioned in your slides, but food for thought, okay? And again, relations. What's anterior? احنا كنا فوق عند البلادر، صح؟ نزلنا تحت. The urethra, base of the bladder and the urethra. What's behind? The rectum, it's still the rectum. The rectum continues down, okay? And then, what else? Inferiorly, it opens into the, we'll see in the external genitalia. It opens into the vestibule. Okay, this is fairly very easy. Go from top to bottom. Here, there isn't a label, but above here, this is called the mons pubis, fibrofatty area that protects the external genitalia, okay? Then you have prepuce of the clitoris. This is a hood. What is it covering? The glans clitoris. Glans clitoris is a very erogenous zone. It's the part of the external genitalia in women that's very, very innervated and usually is related to sexual arousal. Yeah, okay? Then you have 2 labias. Labia majora and labia minor. Majora is the one that has skin and hair, and the labia minora is the one that is smooth and has mucosa, okay? Labia minora has 2 folds, medial and lateral fold. Medial and lateral fold, okay? This frenulum, what is it attaching to? What's this? The clitoris. So the frenulum attaches the labia minora to the clitoris, and the fourchette, I'm guessing this is French, is the ending of the labia minora, okay? Then I have 3 openings. Urethral opening, vaginal opening, and it's not seen here, but the anal opening, okay? Urethral opening is for what? Urination, okay? Vaginal opening is for menstrual cycle, birth, and intercourse. And then the anal opening is for defecation, okay? There are 2 vestibule areas. Vestibule between the labia minora, this area, which is also between the urethral opening and the vaginal opening. And then between the vaginal opening and the anal opening is something called the perineum, okay? Now, as you can see here, it's really, the anus would be right here. So why do you think women get more UTIs? Small distance, right? Because the urethra is right here. All the other openings are right here. That's why usually women are taught to wipe front to back so that bacteria doesn't spread. Otherwise, males, as we will see, rarely get UTIs. Actually, if they get a UTI, usually that's a red flag. That's how rare they get it, okay? And then 2 glands. Paraurethral gland, and then the greater vestibular gland, okay? Both of them are for lubrications and secretions during sexual intercourse, okay? Any question here? Any question of what I explained? Fine. Visualization, okay. This is a procedure called hysterosalpingography. Again, you will not take it, but I put it so you can actually see. What they do here is that they inject a dye into the woman's uterus and vagina. Usually they see this to see if someone's struggling with infertility, is there something wrong in the anatomy? Because if there's an obstruction, the dye won't go. They say, oh, there's a fallopian obstruction, that's why mafish fertilization or implantation or whatever. But the reason why I'm showing you this is because, look, it will draw, look, we see now the uterus side of the fundus, now it's going to the tubes. It's a very nice visualization. We got the same video in our SIVA. If you guys don't know what SIVA is yet, it's fine. But what I want you to see here is look where the dye goes.
Which structure is this?
Where? Where?
This video, the fallopian tube.
Wait. It's the entire thing. We'll see. It's injecting the dye, صح? Hey, it's going through the vagina, okay? Cervix, this is the uterus. Do you see its shape? Do you see its shape? And then, look, it's going into the fallopian tubes. They will get drawn out here. And then you see the dye spilling into the peritoneal cavity. There's a communication with the peritoneal cavity. Whenever there's a communication with any cavity, any structure, anything without any barrier, infections. An infection in the vagina, an infection in usually the vagina, which the uterus. Infection in the vagina can very easily spread to the peritoneum through this route. Does it always spread? No, but it can easily do so. Okay? Now the gentleman. We will start with the testes. Again, primary sex organ, paired. Okay? Covered with a connective tissue called what? Tunica albuginea. Okay? This was explained to you during physiology. I'm not gonna dive deep into it, but there are 3 types of cells in the testes. What are they? Sertoli cells, sperm, Leydig. Great. So Sertoli, which one of these are sex cells? The sperm. Okay. Sertoli cells are supporting cells and they're in the seminiferous tubules. The only ones that are interstitial, between the seminiferous tubules, are Leydig cells, and they are responsible for producing hormones. Fun fact, if a man, la qadar Allah, has cancer in the Leydig cells, do you think he will produce testosterone or estrogen? Estrogen. They get feminizing symptoms. They get gynecomastia, which means their chest looks more feminine, because none of us have 100% sex hormones. I don't have 100% estrogen, progesterone. He doesn't have 100% testosterone. There are still a couple of percentages that are exchanged in the genders. Okay. Again, wasn't really specified for your information here. Okay, what else? Right. The testes create what? Sperm. صح? The first person to get this is the epididymis. Epididymis is a worm-like structure where on the testes? Superior-posterolateral. This is also important. Superior-posterolateral. Okay? And it has 3 parts. The head, the body, and the tail. And the tail continues as the ductus deferens, which we will talk about now. Okay? What are the 2 main functions of the epididymis?
Maturation.
Conveying. Conveys it to the ductus deferens. Okay? Ductus deferens. A lot of relations. Right. The ductus deferens will ascend through a structure here called the inguinal canal. And it forms part of the spermatic cord. Forms part of it. The spermatic cord is anything داخل خارج على the male genitalia. So it's not only the ductus deferens, okay? Once it goes to the inguinal canal, basically your abdominal wall is made up of muscles. Once they reach your hip, some of them turn into aponeurosis. You guys know what aponeurosis is, صح? And when the muscles, subhanallah, جايين ورا بعضهم, and some of them have, I don't want to say a hole, but they're not continuous. But there is a canal that forms called the inguinal canal. Well, this isn't the only structure that passes through it, but it's very important for you to know that it passes through the inguinal canal, okay? Because sometimes the inguinal canal can have herniations. Could be herniations of the muscles, could be herniation of anything else, and that can press on the spermatic cord, okay? Right. The ductus deferens joins with who to form the ejaculatory duct? Seminal vesicles. Very important. So it goes, what is this? The relation. So the ductus deferens is wrapping around the ureter, okay? Then it goes medially, and as you can see here, it's like it's a small narrow tube, and here it becomes wider. This is called the ampulla of. Then these are the seminal vesicles, and they join together to make the ejaculatory ducts. Okay? So what type of sperm does the ductus deferens convey? Mature sperm. Okay? طيب, related to, we said it's behind the bladder, related to the ureter, goes through the inguinal canal. All of that is important. Okay, receives from the epididymis, part of the spermatic cord, runs behind the bladder and anterior to the rectum. Again, so it's kind of similar to the uterus. Okay? Except the uterus was, the bladder was anterior to the uterus. Okay? Joins with seminal vesicles to make the ejaculatory duct. Okay. Seminal vesicle is an accessory gland. It produces what? Seminal fluid. Okay? This and I'll say it when I get to the prostate. Okay? Like relations, the seminal vesicle sits between which 2 structures?
Bladder.
The bladder. Prostate? Bladder. Okay? I'll make sure this information just in case I messed up. If you feel like I messed up, equally add. Okay? It is lateral to the vas deferens. So vas deferens بيجي medially, seminal vesicle بيجي lateral. Okay? And its main function is producing seminal fluid. Prostate. Again, relations are very important for the prostate because of its clinical correlation. Okay? The prostate is inferior to who? The base of the bladder. Higher bladder. Prostate is right here. Okay? As you can see. This is the base of the, so this is, you're looking at someone من تحت. Okay? As awkward as that is. And this is the base of the bladder, this is the prostate. What goes through the prostate and into the penis? The urethra, okay? So this is one of the structures which we will talk about, going through the prostate, okay? Then, what is it anterior to? Yes, anterior to the rectum. We said it's inferior to the bladder, anterior to the rectum, posterior to who? Yes, pubic symphysis, exactly. Pelvic, the pelvis يجي قدام, pubic symphysis. So bladder is posterior to the pubic symphysis, anterior to the rectum, inferior to the bladder, okay? And what's its main function? Also produces seminal fluid. Prostate and the seminal vesicle both produce seminal fluid and they make the bulk of semen. The semen is made up of two things, seminal fluid and the sperm, okay? Bulbourethral glands are also called Cowper's glands and they are on either side. This is called the pelvic diaphragm, by the way, just for your information. And here you have the bulbourethral glands. What are they responsible for?
Lubrication.
Lubrication, exactly. It opens into some island. Which one?
Sponge. Or the penile.
Yeah, it opens the urethra. I'll make sure which kind. This is the prostatic. This
Yeah,
is غالبا it opens into the membranous or spongy. One of them. Okay. What does it secrete? We said it's located under who?
Prostatic.
It's located under the prostate. Okay. The penis. It's the external genitalia of the males, and it has erectile tissue. It has 3 erectile tissue. 2 of them are paired. How do you remember this? Corpus cavernosum, CC. They're paired. 2 C's. Okay. And then you have corpus spongiosum. You remember it because the urethra going through the penis is called the spongy urethra. A corpus spongiosum. During an erection, these tissues fill with blood. That's what causes it. Okay. Then tunica albuginea also wraps this. So it does not only wrap the testes, it wraps also the penis. Okay. And then you have skin, superficial fascia. There is no subcutaneous tissue here. Okay, that's also important to know. Urethra, depending on where it is, it has a different name. So if it's in the prostate, prostatic urethra. If it's in the penis, spongy urethra or penile urethra. In the middle is membranous urethra. That's basically it. And then also, goes back to the point of the UTIs. This is exactly why men do not get UTIs. It's very far away from the anus, from everything else. So it's less likely to get contaminated. Okay? A 42-year-old woman is admitted to the emergency department with severe abdominal pain. MRI reveals a tumor at her left ovary. A frozen biopsy during the time of surgery reveals an ovarian carcinoma. Which of the following actions can be performed to reduce the pain?
A?
Yes. Why?
Because it's the one that has the vessel.
It has the vessels, it has the nerve. You cut the nerve, no more pain. خلاص.
So that's the other name for the suspensory.
Yes, another name for suspensory ligament is called the infundibulopelvic ligament. I don't think they're going to get you that name, but I get questions like these so that you don't get scared by the length of a question. You could have a question this big with the actual information they need from you is the last 2 sentences. By the time you reach the last 2 sentences, خلاص. Yeah. Read. Someone read. Read.
A 42-year-old woman visits the outpatient clinic due to painful urination. A dipstick test reveals leukocytosis, which confirms the diagnosis of UTI. Which of the following is the best anatomic explanation for the fact that women are more susceptible to urinary tract infections than men?
C. Urethra is much shorter in women than in men. Okay. This one, the only reason I put it is, I don't think you're going to know the answer to this, but the only reason I put it is because it's related to a photo you have, and if they want to get tricky with you, they can do this. فأحسن لكم you know it بدل ما you don't. A 47-year-old woman with 3 children and a family history of breast cancer mutations in the BRCA1 and BRCA2 genes has made a decision to have an elective hysterectomy. I'm going to teach you the clinical correlations through the question, by the way. As a prophylactic treatment, during ligation of the uterine artery, which of the following adjacent structures is most susceptible to injury? ما جبتش سيرة internal iliac artery. Okay. Again, this is kind of for your information, but again, لو عايزين يلعبوا معاكم ممكن يجيبوا لكم سؤال زي ده. These were what? The ovarian, صح? This is the uterine. These are the uterine vessels. مين جنبه? The ureter. The way we learned it is water under the bridge, because the ureter transforms urine or transports urine for water under the bridge. But if someone is having a hysterectomy and they're ligating these vessels, they can very easily injure the ureter. Again, for your information. ما تخضوش قوي كده. Okay? Yeah. This one is related to physiology. 32-year-old woman is admitted to the hospital, intense lower abdominal pain, blah 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 blah. And yes, uterine tube. Ectopic pregnancy is most seen in the uterine tube. طبعا it can be in other areas, but this is the most common. Okay? A 60-year-old woman presents to her primary care physician complaining of a feeling of heaviness in her pelvis and protrusion from her vaginal canal, especially after prolonged standing, as you see. She has a history of multiple vaginal deliveries and chronic coughing. These two are keywords because they are telling you there was a lot of increased abdominal pressure. Do you know what holds up the uterus? You guys will not take it, but between the uterus and outside في حاجة اسمها pelvic diaphragm. It's made up of a lot of muscles. Things like birth, increased intracranial pressure, so مثلا someone who's weightlifting in a bad way, for example, increased intracranial pressure can weaken those muscles, and thus very easily a prolapse can happen. Literally the uterus falls, which is amazing for us women, but it can happen. Okay? This is also why post-birth, usually they tell women to do pelvic floor exercises. There are many. Physiotherapists help with those things. Males. The part of the male reproductive tract which carries only semen within the prostate gland is what? Yes, it's E. Only semen.
Oh, like they mean without urine?
Yes, without urine.
Yes.
تفكرتني what I mean here. That's good. Semen without urine. Why? The urethra does not only transport urine in males, it also transports ejaculation. Okay? We can go back here. Go back هنا. See? Ductus deferens, urethra, جاي مع السمن الباسكال عمل لي ejaculatory duct دخل على الurethra على طول. So ejaculation comes out of the urethra in males. In females, no. And that's from the vagina. Okay? Do you guys know why it doesn't mix? Okay. A 6-month-old was brought to the pediatric clinic by his parents because of leakage of urine from the ventral surface, ventral يعني top surface, superior surface, or anterior surface. This congenital condition is called hypospadias, you will take this later, is due to incomplete ventral closure of a component of the penis. Which of the following structures would be partially open for urine to take such a course? I think. Yes, it's D, because it's spongiosum. If I wrote something else here, it will look very bad. Yes. Spongiosum, because we said corpus spongiosum surrounds the spongy urethra. Okay? Question 12. 72-year-old man. This is very important. I will guarantee you will have a question about this clinical correlation. Gets up several times during a football match to go to the restroom to urinate, even though he has had only 1 beer. This is a problem that has plagued him for 4 years. When he goes to a physical checkup, on physical examination, he has a diffusely enlarged prostate, palpated on digital rectal exam. Lab studies show elevated prostate-specific antigen. What does he have? المفروض it's BPH. المفروض it's benign prostatic hyperplasia. مش إيه؟
enlargement of the prostate.
Yeah. I wanted to. I'll fix this question. بس هو تلاقيها nodular hyperplasia. يعني it's benign prostatic hyperplasia. I don't know why the options are like this. But it's benign prostatic hyperplasia. Okay? طيب. You have 2 clinical correlations in your slides: benign prostatic hyperplasia and carcinoma. Both technically are enlargements in the prostate. A tumor is an enlargement. Okay? So it can press on the urethra here and press on the urethra here. How do you differentiate between them in a question?
Benign or malignant?
How? هتعرفي منين? The clinical scenario gives you clinical symptoms. Do you know the difference between them? Carcinoma is what is a cancer. very important symptom of cancer is unexplained weight loss. The clinical scenario will have, he has unexplained weight loss for a good amount of time. He may also have hematuria, which is also very common in carcinomas, which is blood in the urine. Okay, and usually they can have, by the way, urination problems, but it's not in the beginning. It's usually in the end. Okay, so in the beginning, usually these are asymptomatic. These, though, are symptomatic. And the biggest problem here is urination, because he's compressing the prostatic urethra. They cannot fully empty the bladder.
So frequent urination.
Yes, frequent, and they never feel like they can fully empty. The micturition itself is not taking its full course. يا دوب حتى they have to strain, and either they have to strain or من كتر ما the urine can get retained, they have dribbling of urine. Okay? Yeah. يلا someone read.
B.
Yes. A 35-year-old man undergoes a vasectomy as a permanent form of contraception. Several weeks later, he reports for a follow-up testing. Which of the following components would still be present? What happens in a vasectomy? I didn't add the photo. What happens in a vasectomy? The vas deferens is cut or ligated. There is sometimes reversible vasectomies, but مش مشكلة. They cut the vas deferens. Why? Because it's the thing that conveys sperm. If I don't convey sperm, خلاص, very low. يعني if there is a chance for pregnancy to occur. Sometimes they have failed. I'm not sure why. But the whole idea is you cut the vas deferens, you don't convey sperm. ما فيش sperm to fertilize the egg. خلاص, no pregnancy. Okay? So what am I going to be left with is the seminal fluid. Because again, the seminal vesicle and the prostate will still be fine. They will still produce their fluid. It's just the sperm is not part of the semen anymore. Okay? 68-year-old man is admitted to the hospital with complaints of complaints of lower abdominal discomfort and inability to urinate for the past 12 hours. He has history of BPH. On physical exam, his bladder is distended and tender. Which of the following is the most appropriate management step?
C.
Yes. By the way, this is an emergency. This is a big medical emergency. If someone's coming with urinary retention and a distended bladder, immediately catheter, or حتى sometimes not even a catheter. There's another clinical thing that they do. I forgot the name, but they insert a needle right here to drain it from above, not even waiting for a catheter. Okay. So these are the two clinical correlations. Vas deferens here is cuts the vas deferens, is crushed and ligated, and then here urinary catheter. طبعا this goes for both women and men, although in women it's harder to get into. Question 15. 28 I think it's either the last question. Yeah, this is the last question. And this is very important because I went through your objectives in your lecture, and this was stated very clearly. And you have to know how to do this, or how to recall this. A 28-year-old healthy male is undergoing evaluation for infertility. Semen analysis reveals normal accessory gland secretions, but absence of spermatozoa. Further investigation shows an obstruction in the reproductive tract. Which of the following structures is the last to carry spermatozoa out of the body? E. Exactly. External urethral orifice. Please know this. Madam, it was stated this clearly as an objective. You will have a question about it. And no, the course of sperm from being produced up till it leaves the body. So what do you have here? Seminiferous tubules. Then seminiferous has efferent ductules with the dubuline epididymis, head, body, tail. Tail goes to ductus deferens, or vas deferens. It's the same thing. Vas deferens to the ampulla joins with the mean seminal vesicles to make the ejaculatory duct. Ejaculatory duct بيفتح على مين? Prostatic urethra, then the membranous urethra, then the spongy urethra. The entire, yeah, you can see هدول ثلاثة urethra, okay? Then finally exits through the external urethral orifice. This is a mnemonic that I definitely 100% made up by myself, and it was definitely not AI على طول. And if it can help you remember, this Viking over here, okay? Inshallah, you ace it. If you guys can just do the feedback before my friends start. Oh yeah. Okay. If you guys are, did you guys do it? For you. Sorry لو طولت عليكم.
Alright, Alright, so my name is Assia and I'll finish off with the anatomy review today. So the first lecture that I'm going to cover is joints. So basically in this lecture it was mainly about different classifications of bones. So either the bone itself or the bone formation. It's not a difficult lecture, so inshallah you'll do well with it. So here we have the first classification is by amount of solid mass. So we can see it can either be compact or spongy. What's another name for spongy? Yes. So the compact bone is well organized in osteons. I'll speak more about osteons later. And it's important for weight bearing. While the spongy bone, it consists of trabeculae. So as we can see here, it's kind of mesh-like, so there is spaces. And these spaces are filled with red bone marrow. So as you can see here, usually you're going to have the outer covering, which is compact bone, and inside there's going to be cancellous tissue and the marrow within it. And so you can see here, this is the skull. There are two layers. So this is a cut from the bone. So you can see the outer layer and the inner layer are both compact. And the middle layer, it's clearly more spongy. You can see holes here. It's more mesh-like. So just the locations usually for the compact bones. So in the shafts of long bones, the outer covering of flat bones, so like in the skull, for example. And yeah. Now another classification is by microscopic structure. So we have primary or woven bone and secondary or lamellar bone. So earlier when we were talking about spongy and compact bone, both exist at the same time in a normal person. Here it's primary goes into secondary. So normally most of the bones in your body have a secondary structure. The primary structure is mostly either in fetal life or in repairs. So if you have a fracture, for example, it's going to get repaired through primary first and then goes into secondary. So the primary bone, it's made from, it comes from cartilage, made of type 1 cartilage. It's low in minerals, so it stains blue. The blue comes from the collagen. So you can see here, it may not look blue, but it looks purple. It looks less pink than this picture. And so the secondary, as we said, it's what we have in the adult bone. It's calcified, and since it's the mature bone, it can either be spongy or compact. So a question for you guys, this image, can you tell if it's spongy or compact? Compact. Alright. Now for the haversian systems, or the osteons. So we can see the structure of bones. Basically, the idea is that it's concentric circles of lamellae that surround a canal called the haversian canal. And this canal is going to contain blood vessels and nerves, so it's going to supply the bone from within. And there are canals called perforating canals or Volkmann's canals that connect one osteon to another. So you can see here, for example, or here. Here you can see the transition into spongy bone, where it's more, where it's not the same structure, it's more in trabeculae. So. Alright, so now for another classification, now for bone development. So there's two ways that bones can develop, and it's not one way and then the other. It's in different places, different ways. So you have the intramembranous and the endochondral. Oh yeah, just for clarification, ossification, osteogenesis, histogenesis, bone development, all that is the same thing. So intramembranous is directly from connective tissue to bone. Endochondral is from connective tissue to cartilage to bone. So here we're going to see a difference in the cells that are present in both. So can you tell me what kind of cells can we find in intramembranous?
Fibroblasts.
And?
Still.
Yes. And in endochondral, what do we have more?
Chondro.
Yes, exactly. So the intramembranous form from a single central ossific center. So basically, the bone development will go from one place and then spread. And this is found in the roof of the skull, the mandible, the clavicle, and it could give either spongy or compact bone. Now for the endochondral, there are primary and secondary ossific centers. So in the next slide, you can see the primary is in the middle, and then there is a secondary in the epiphysis. I'll come back to this later. And the secondary forms after birth in the epiphysis, and it's responsible for the growth in length. I'm not sure if you guys took the term, but the growth in length is interstitial growth, and the growth in width is appositional growth. So if you guys didn't take it, doesn't matter. The important thing is that the endochondral ossification only forms spongy bone. Alright. Oh, one last thing. The bone at the very beginning, we said that it was connective tissue in both intramembranous and endochondral. So, embryologically speaking, where does the connective tissue come from? Alright, so here we have the intramembranous and endochondral. So you have directly osteoblasts that form from the connective tissue mesh, and then they just spread and they become more and more vascularized. While here for the endochondral ossification, we see at the beginning it's the same in the primary ossification center, but then wait, no, it's not the same. At the beginning, there's cartilage. We start with the cartilage, then there's going to be an ossification from the middle, and then later there's going to be another ossification center in the epiphysis. And you can see, let me go back here. This is the epiphysis of the humerus. So you can see in a child, it's not formed, it's not calcified. You can see this black line over here. So it's not calcified because the child is still growing, so the length of the bone is still going to be variable. Alright, this is for the growth in width, so as I said, the appositional growth. So you can see it happens from the periosteum, so from outside, those lamellae are going to form ridges and then enclose the blood vessels, and then new blood vessels will come on top, and that will just increase the area in width. Alright, so that's it for the joints. So now we move on to CDS2. So this is about blood vessels. Again, not a hard lecture. So first we have different types of circulations. So the first two are pretty easy, systemic and pulmonary. We all know them. Pulmonary go to the lungs to oxygenate the blood. Systemic go to the rest of the body to supply them with oxygen. Then we have the portal and coronary that are a bit special. For the coronary circulation is the circulation of the heart. You can see here some of the most important vessels, like the great cardiac vein, the sympathetic artery. I don't think this is required from you guys, but just as an idea. And then we have the portal circulation. So here it is in more detail. So just remember an important thing: the portal vein is not the same as the hepatic vein. It's easy to confuse them because they're both veins in the liver, but they're not the same. So what happens here is that, do you guys know the main function of the liver? So basically, anything that comes in the GI tract will go through the liver to get detoxified before going to the rest of the circulation through the heart and etc. And this venous blood is going to go through the portal vein. And then the portal vein within the liver will break into sinusoid capillaries. So for the structure, basically it starts from the spleen and the superior mesenteric vein, this one coming from the GIT, and both of them join to form the portal vein over here to join into the to go into the liver. Now, just a brief overview of the difference between arteries and veins. So, arteries give branches. In your lecture, it was described as like a tree. So, from one big branch, it gives smaller branches. For veins, it's the opposite. It's receiving smaller vessels to become one larger vessel. So, like rivers. So, the arteries go from larger arteries to arterioles and then capillaries. Then those capillaries will become venules, which will then become veins. So it's all connected. Arteries are often accompanied by either one vein, if it's a large artery, or two veins for medium arteries. And when it's two veins, those veins are called venae comitans. So here, this is an example. We have the anterior tibial artery and the anterior tibial veins. So we have two veins following the same artery. And another thing about veins is that they could be superficial or deep. So usually when they're deep, they're accompanying the arteries. Alright, now just about venous valves. So limb veins, so in the arms or legs, usually have multiple valves. And the reason for multiple valves, actually, can you guys tell me why do we have valves in the veins?
Prevent backflow, because there's no pressure, so we have to move the
Exactly. So yeah, there is not enough pressure to drive the blood up, and also there's gravity that pulls the blood down. So the valves are necessary. In the neck veins, we have only one pair of valves at the termination of the vein. And for the thoracic and abdominal veins, there are no valves. There's no need because they're pretty close to the heart. Here we can see what happens if there is a dysfunction in the valves, and this is a case of varicose veins. So you can see here the vein is tortuous. It's not flowing straight as it should be, and because of that, the valve is deformed, and this leads to blood pooling. And because of the pooling, you can see it from the superficial layer. So when you look at the patient's legs, you can trace the veins because of the blood pooling within them. All right, now we're going to talk about blood vessel communications. So there's 4 types of communications. The usual normal one is through capillaries. So as we know here, we have arterial on one side, venual on one side, and then you have smaller capillaries that are very small, just big enough to let the blood cells pass through. Here we can see that there can be some narrowing of the precapillary sphincters. Again, I'm not sure if that's with you. I don't think so. And yeah, you also have anastomosis, which are direct communications. So without these structures in between. And I'll speak more around that in the next slide. Then we have sinusoids. So we just saw an example of sinusoids. Where was it? Liver, yes. Just after the portal vein. It's also present in the spleen and in the bone marrow. So do you guys know the function of sinusoids? Why do we have sinusoids?
Macrophages are going to be present around, and they're going to have them.
Yeah, basically it's anywhere you need filtration or you need large cells large proteins to pass through, so it gives a wider area, so there could be more movement. Then there's cavernous tissue, which I believe is only present in one place, which is the penile tissue, and it's made of small spaces that are lined with endothelium and separated by septa. Alright, so now more on the anastomosis. So there are two types of anastomosis, either between two arteries or between an artery and a vein. So between two arteries, you often find this around joints. So for example, this is, you can see the arteries of the foot. So you can see they're splitting and then connecting again, and then splitting again, and then connecting. And it's all of them are kind of continuous. It's the same thing for the hand. There's a similar thing in the brain, around the GIT, etc. Then there are anastomosis between arteries and veins. So this is present in the dermis to regulate the temperature. It's present in the nasal mucosa, the tip of the tongue, the intestine, and some erectile tissue. Now, end arteries, they're arteries that do not anastomose. So we've talked about all of these anastomosis. We mentioned here that it's for that in the dermis, for example, is to regulate temperature. But what about the anastomosis around the joints? What's the function of that? Why do you have anastomosis?
It's like there are spaces between the two bones.
But there are capillaries to fill those spaces.
Capillaries would be too fragile, especially since they're joints.
No. Basically, think of it as for one area that can be supplied from two arteries. So in case one artery is blocked or damaged, the other artery can supply. So that's why in end arteries, if there is an occlusion, it will lead to ischemia, which can be very dangerous. For example, there are end arteries in the retina, the brain, the kidney, and spleen. So if there is if there is an occlusion in the retina, it will cause blindness. If there is an occlusion in the brain, it will cause a stroke. So it's very dangerous. And that's also why in the coronary arteries, so around the heart, there are many anastomosis to kind of decrease the likelihood of myocardial infarction. Although they still happen because the anastomosis sometimes aren't enough. And finally, just a mention of wavy arteries. So they have a particular shape because they're there to accommodate moving tissue. So you can see here around the uterus, on the face, because we need to move the facial muscles to speak, to laugh, to do anything. We have here in the tongue, and here in the spleen. And yeah.